Hi, it's Dr. Centeno, and welcome to today's show. You've got the power. Today, we're going to be focusing on an interesting topic, and that is what's going on in your neck causing sleep apnea or snoring or obstructive sleep apnea. Now, kind of interesting thing, we're going to focus on more the structural components of sleep apnea. Sometimes it can be due to problems like taking too many sedating medications, that kind of thing. So as usual, I'll start with a quick presentation on this topic, and then we'll go from that quick presentation on to questions, whether it's about that topic or any other topic you want to ask about. So let me get that started. I will share my screen here, and we will get going. Okay, so let's start with can sleep apnea be caused by what's going on in your neck? Sleep apnea is also known as obstructive sleep apnea, snoring. Again, we're going to focus on the mechanical aspects of sleep apnea today rather than some of the medication-based aspects of this problem. So snoring is really considered, I think, by most people to be more of a nuisance than anything, and not something to be concerned about. And when something blocks the airway, that can be called snoring, and that's when you've got sort of a partial obstruction. And then a lot of people who snore have episodes of obstructive sleep apnea where they get a complete block of the airway and they basically stop breathing, and then that causes them to move, and then the airway opens again. And it's those obstructive sleep apnea episodes that can really cause problems. Now, what's happening here with all sorts of sleep apnea is that means that your blood oxygen level is going down. There's also changes in heart rate. There's also changes in blood pressure, all of that good stuff. And obstructive sleep apnea can increase your risk for developing type 2 diabetes, increase your risk of having a fatal stroke, and having a fatal heart attack. So realize that snoring in general is not something to be taken lightly, even though most people do take it pretty lightly. So can your neck be involved? Can your neck cause the snoring or the sleep apnea? So we're going to take a look at that. I didn't see any great diagrams out there to illustrate this that already existed. So I basically drew my own. So this is sort of my own art here. But basically, we've got a mouth there. This is the nose. You bring air in through one way or the other, and it goes down into your trachea. And that's how it's supposed to normally work. Now you can see in a couple things here. In this area, you got a spot for a potential blockage. And notice how there's not a lot of room between the cervical vertebra here and the airway. Also notice that the esophagus is also close there. So that gets more into people that have swallowing problems due to their neck. So if you've got, for instance, C1, C2 instability, in this case, where C1 is coming forward of C2, and that's an increase in what we call the atlantodental interspace, or the ADI, that can put pressure on this part of the back of the throat, and that's going to narrow the airway. So the air is going to come in, and then it's going to kind of get turbulent in there, and that's going to cause a decrease in your ability to efficiently get air into your lungs and keep your oxygen levels up. Now, C2-3 can also impact the airway, and look kind of where it's located. It's located in that really tight juncture there. So we have C2 coming forward there and really reducing the size of the airway. And realize that that would be increased, for instance, when your neck is in flexion like on a pillow and you're lying face up. That could be mitigated when you're lying on either side. Now, obviously, if you have C1, C2 side-to-side instability or overhang, that can also cause problems if we had this model set up so that we can see side to side. But this is just right now looking from the front because it's easier to conceptualize and it's easier for me to draw. And then finally, cervical kyphosis can cause problems with the airway. When you have a normal curve in your neck, that's going to tend to open all of this up. But when you lose that curve and it starts going the other direction, that brings this closer to the epiglottis here and causes, again, another restriction in the airway. And there was just a recent paper published on this that Dr. Katz had highlighted. And it's a really interesting one because it shows that there's a direct relationship between that change in the curve and sleep apnea. So I just showed you a bunch of stuff and it all looks logical based on how the pictures are, but is there research that kind of connects these dots? And the answer is yes. There's lots of different studies. I only included 3 here that links all the stuff we talked about in general to sleep apnea. So if you snore, in conclusion, what should you do? Obviously, if you've got a neck issue, get the neck treated. If it's a loss of curve, get that treated. If it's instability, get that treated. And then obviously, you're going to have to see a sleep specialist for a sleep study. And realize that when we see patients for the PICL procedure, and then sometimes just for other neck injections, I'll be doing the anesthesia myself. So I'll see that they have a sleep apnea problem. And don't be surprised, and we've done this with a lot of patients, if you wake up and we say, you know what, you really need to get your sleep apnea looked at because we saw it when you were asleep on the medication. And a sleep specialist is really the next thing for a sleep study. So we do that all the time because this is a public health concern, meaning and a personal health concern for that patient, going beyond just the fact that their neck hurts. So let me switch this out here and I will stop sharing the screen. And then we can go and try to answer some questions. So Larry, hey, I got a bit of a tick and the doctor put me on doxy. I'm assuming that's like a bug tick rather than a movement tick. Do you see any issues with doxy in my neck ligaments? Larry, doxy shouldn't be an issue with your neck ligaments, no. It's been advanced by Harry Winston. Is sleep apnea possible in young people? Would it only affect older people given the same set of issues? You know, sleep apnea is in general going to affect older people more than younger people. So being older plus having a neck issue just sort of adds 2 components that could cause problems. I wish I could pronounce that name, but I can't for the next one, so I'll put it up. Hi, Dr. Centeno, may I ask about how does PICL treatment affect the 0-1 joint stability? Does alar ligament provide significant stability for C0, C1? Yes, it impacts all of that. Let me see if I can find an image to put on the screen that would explain how, for instance, alar might impact the 0-1 joint. So again, let me look through some images here to see if I can find one that'll help explain that better. I don't think I've got a great image for that one. This one's not bad. Let me try this one here. So I'm going to share my screen again here. And we'll put that up. So I'll have to draw a few things in here to kind of talk about how, in this case, the discussion is, does alar impact the 0-1 joint? So this is going to be part of the 0-1. That's the C0 part. There's going to be obviously the skull that comes in here through the occipital condyle. And so this is going to be C0 C1. Now, realize that what alar is doing is it's going up to the skull and it's holding tightly C1 against C2. So it's that compressive force of C2 pushing up through the C1, C2 joint that is, and then up through the skull that's pushing the C1 into the skull or the occipital condyles. So alar is involved in 0-1 stability. Now, there are lots of other things involved in 0-1 stability. For instance, again, we'll draw it on the side here. You've got an occipital condyle and the skull. This is C0, this is C1. And you've got obviously ligaments up front here that are involved in stabilizing 0 on C1. And you've got ligaments in the back here, and then ligaments back here that also are involved in that stability. So quite a bit going on there. Now, the transverse ligament, I think, is less involved in 0-1 stability because that's going to come around here. Actually, I've got it drawing on the wrong side there. My bad. It's going to come around here. So that's the transverse ligament. So that's going to be less involved. Then you've got the accessory ligaments that bleed up to the alar ligament. So those are also going to be involved. So hopefully that answers that question. May have been a little bit more complex than you were looking at, but it's you can see, I think, how the two are connected. Mark, which ligaments limit sacral nutation? Which ligaments limit counternutation of the sacrum? You're talking about some interesting movements there. Those are basically movements that come from osteopathic manipulative care. So let's see if I can get some good things to show you here so we can look at that in more detail. So this one might work. Mark, hold on a second. I'm going to try to put this into a little PowerPoint so I can draw on it and show you what's going on. Okay, that'll probably work. Okay, let me share my screen again. And then we'll put this whole thing up. Okay, so nutation, counternutation, these are all terms that talk about what happens with the ilium and the sacrum, and nutation happening when the sacrum comes forward here or goes clockwise and the ilium goes counterclockwise. Obviously, counternutation, the opposite of all of that. Now, there'll be a lot of individual ligaments that can impact that, and they're drawn pretty nicely here. So we've got the SI joint ligaments here, and those SI joint ligaments include short dorsal, long dorsal, and then all the ligaments that attach at the inferior lateral angle of the sacrum, sacrotuberous, sacrospinous, that go down this way and become eventually confluent with the hamstrings. So if you have instability there, it would be treating all of these ligaments, including sacrotuberous, sacrospinous. Also realize that not shown in these images is the symphysis pubis up here where all this connects. And that's another area that has ligaments that would need to be treated because that's the front, and that can slip up or down, and a millimeter or two up front because of the lever arm produces much more motion in the back. So those are all ligaments that would be treated in that type of situation. Okay, let's see what else we got. It's been advanced by Carly. If a correctable issue like a neck problem isn't found, What do you think about the Inspire device for confirmed sleep apnea in adults? The Inspire device. That's a new one. I don't treat sleep apnea other than treating people's necks. So let me look at that one to get a sense of what it is. Yeah, so implantable stuff. Not a big fan of implantable devices, simply because implantable devices fail, the wires migrate, et cetera, et cetera. So putting in a neurostimulator for the hypoglossal nerve is sort of an extremely invasive way to treat this problem. Hence, I wouldn't really go that direction. You can treat sleep apnea much less invasively, obviously, by treating the neck. You can also get put on CPAP, which is positive airway pressure. You can get small devices that'll push the mandible forward and do what we do when we're doing anesthesia to open the airway. And that's, again, manually push the mandible forward. So again, like anything else, you want to start with the lowest risk way to treat something. And if that doesn't work, then go to a higher risk. And that's really what this show is about, right? Teaching patients that just because there's a new device that you would implant and then invasively tunnel a bunch of stimulator lead wires, doesn't mean that that's what you should do, because that's going to be more invasive than all the things I just discussed. So, keeping patients safe is about trying the least invasive way to try to solve the problem. And only if that doesn't work do you go to more invasive things. So this might be a good way to treat somebody if all those other things had failed, but it certainly would not be a starting point for treatment because it's much, much more invasive than things like CPAP or a little device you put in the mouth to kind of move the mandible forward. Mark, hi, doctor. I have two major issues. One is all through the neck, C1, C2 of naturally fused and up in the back of the head on each side. And then my front ribs constantly pop in and out all day. I have to put them in myself. I see a chiropractor 5 days a week. So it's severe. It makes it difficult to breathe and heart rate goes up sometimes when the front ribs are out. So again, if there is instability market C1, C2, and that's not able to be treated through things like AO chiropractic, NUCA, sounds like you're seeing a chiropractor a lot, I'm assuming, to adjust that and the ribs, then the next step would be tightening down the ligaments that hold all of that together, and that's through injection. Usually, for instance, just to focus for a second on rib instability, that's commonly treated with injections to tighten down those ligaments, whether that be platelet-rich plasma or other stuff. So we frequently treat rib instability by tightening down the ligaments where the ribs attach, but also tightening down the fascia that covers the ribs. If you recall eating ribs, the kind of ribs you might get at a steakhouse or something, you'll notice there's a tough fascial covering on the ribs. And your body has the same thing, and that fascial covering helps to provide stability for the ribs. So sometimes that needs to be treated. Peter, thanks for this. It's a great topic. What kind of doctor would you see for a sleep study, and how would you best explain your condition to them? Also, can CCI cause both mechanical and central apnea? Yeah, good questions. As far as what kind of doctor, that would be a sleep specialist. So an MD or DO sleep specialist was where you would start. And I think the best thing to do, obviously, would be if you think it's CCI causing your problem, then you need to see one of the very few doctors that specializes in CCI to try to treat that. So you could certainly tell your sleep doctor, hey, I think it's coming from my neck. I understand there's some research that shows those two are connected. I'd like to see if I really have sleep apnea. So can we do a sleep study? And then you might say, well, we're going to treat my neck next, and then we'll see if my sleep apnea goes away. And then you could redo a sleep study. And then if it doesn't go away, you can always do things like CPAP, et cetera, or perhaps you could even get placed on CPAP before the treatment starts. That kind of stuff is what the thinking would be. Levon, can you have CCJ instability without an overhang? Sure, Levon. There are other types of cervical instability. The transverse ligament, where the dens comes too far backwards in flexion. There is 0-1 instability that is generally going to be harder to detect on something like DMX. So yes, you can certainly have CCJ instability without overhang. Ravate, do PRP or stem cell injections dissolve a trigger point? A trigger point consists of a couple different things. A trigger point is generally caused by an irritated nerve that goes to a muscle, and then the muscle develops a locked tight band. So rather than the muscle going through contract, relax, what instead happens is it gets locked in that contracted position. So all you really need is a needle. An acupuncture needle will usually do it. Get it into that tight band and it'll release. The problem is if you still have nerve irritation going to that muscle, then you're going to just get the tight band back again. So you've got to treat the nerve irritation as well to get rid of it. So dissolving it, no. But if you treat the right nerves going to the right muscles, you can get rid of them. Anya, hi, Dr. Centeno, a very important question. This week, an online consultation with Dr. Kirkor, he said that from his experience, injecting ligaments and muscles doesn't help long-term if a person has EDS, that it helps with the instability caused by trauma, but not EDS. He said that he can do facet injections to help with arthritis, but that from his experience, injecting ligaments only helps with instability for a few weeks if a person has EDS. Not our experience at all. In fact, I often recant or recall my niece, who's actually in the UK right now because she went to Cambridge for graduate school. We've treated her EDS, and I've treated now hundreds of patients EDS with various types of ligament injections. Now, it's not going to change the fact that you produce stretchy collagen. The goal is to stabilize specific areas and get those thicker. So they're stretchy ligaments, but they're thicker, so they provide more stability. So that's not been my experience at all. And I've treated EDS patients now for a very long time. So we can generally help them. Now, is it possible that an EDS patient has a rare variant that doesn't respond to certain things? For example, my niece has a rare variant of collagen 10 production. She knows that because she was at Cambridge, she got a full genome sequencing, which is pretty rare these days. And so, for instance, prolotherapy worked, and bone marrow concentrate worked very well for her, but PRP didn't really move the needle for her. That's different than most EDS patients we see. But again, most don't have a rare collagen 10 deficiency either. Mark, my sacrum typically gets stuck in nutation, rotated forward. In my previous 3 platelet treatments, only the short and long dorsal SI joint ligaments were injected. It seems that I likely would not see this issue resolved unless sacrotuberous, sacrospinous ligaments are treated as well. It is possible that treating only the short and long dorsal SI joint ligaments, which limit counternutation, can make the sacrum more likely to get stuck in nutation. Yeah, listen, Mark, there's a lot more than just treating the short and long dorsal SI ligaments, which I think you've surmised. You also need to treat things in that case, like the sacrotuberous, sacrospinous ligaments, and then the symphysis pubis up front. And oftentimes the symphysis pubis is pretty critical. And let me show you why here. I got to find a picture of it first. Okay, this is a good picture. Let's get that into a PowerPoint presentation. Okay. So we have here a pelvis, right? And we have an SI joint back here, an SI joint back here. And we're looking at the pelvis from the front. And this is the symphysis pubis up front. Now, this is a really long lever arm here. So any small amount of motion that we can get rid of up front here is going to transfer into larger amounts of motion back here because of that lever arm. So frequently, you've got to treat those ligaments you talked about, right? And I'll draw them in here. So there's the sacrospinous going that direction and the sacrotuberous going that direction. I'm not doing a great job here, guys, but trying my best with the mouse. As well as the symphysis pubis. So a lot more to treat it usually than just the short and long dorsal SI joint ligaments, depending on what's going on with the person. Now, there are people where you can treat just the short and long SI joint ligaments, and they'll do just fine. But sometimes, if this is a persistent problem, you've got to treat all of the above rather than just some of those things. Hold a second, guys. I don't think I should share my screen. I may not have. It's not the first time I've forgotten to do that, so sorry about that. Okay, so let's go over that one real quick again, because I may not have, you guys may not have been able to see that. So again, symphysis pubis up front, SI joint in the back here. And as we talked about, treating the sacrospinous ligaments and treating the sacrotuberous ligaments, but small amounts of motion up here, if we can limit those, equals larger amounts of movement back there. So many times you've got to treat all three. Hopefully you can see all that. But over the Caring medical website, you can get rotational instability of C1, C2 from calcified styloid. Not that I have ever seen, nor would that make much sense, right? If you've got a calcified styloid, it actually wouldn't necessarily impact what's happening at C1, C2. So doesn't really make sense at all, meaning the stylohyoid ligament, stylomandibular ligament, etc. So let's pull up some of those, see if I can find some good pictures here. See what we got. Okay, this is a pretty good one. This is actually, I think, from one of my blogs a while back. Okay, so let me share that screen next. Actually, I'll share my screen first. Then we'll share this. Okay, here we have ligaments that get calcified, including muscle tendons, etc. And those ligaments are going to go from either down towards the hyoid or over towards the mandible. Neither of those have much to do with what's happening at C1, C2 way in here. Now what you might see is because of excessive rotation at C1, C2, that could be putting additional pressure on these areas. And again, Sienna, I've talked to you about this before. You're thinking about this backwards, right? The real way this would happen is that trauma would lead to calcification. You're thinking that it goes the other way, that calcification then leads to trauma. That doesn't happen. There's a reason it's calcified. It's not calcified because you were born that way. It's calcified because the ligament tendons, etc., are getting traumatized. And because they're getting traumatized, they're getting calcified. So then the question becomes, what's causing the trauma in order to really understand how to fix it? So it wouldn't make sense that the result of trauma is then leading to something happening at C1, C2, because they're not even connected. Yeah, I think I fixed that one, Mark. So thanks for bringing that up. Yeah, see, and I'm probably going to stop answering your questions because the last couple of times you've just been not very kind here. And I think I'm going to have to start blocking you from these types of Q&A sessions because you're just sort of getting nasty. And I don't know why. I think you've got in your head what it is that's wrong with you, which is wonderful. It's my job to see if, to provide feedback to see whether all that makes sense medically, or if you're getting led down a rabbit hole, and you're kind of getting led down rabbit holes here. Rotational instability has quite a bit to do with alar and transverse ligaments. That's in the book. You can read that. So again, I think this will be the last question I'm answering because I don't think you're adding to the discussion. You're just kind of angry about something. I don't know what it is you're angry about. Especially since I'm taking my time here to answer your questions. And if you see any other doctors online doing this twice a week, you let me know. Anya, thank you for the answer. Are there any examples like before and after of people with EDS? Maybe in the Regenix website, is there any data on EDS patients with alternative injections? Do I understand the clinical trials of Regenix for people with trauma? A lot of people with EDS I've seen online, can't find any info on EDS patients. Anya, no, I mean, there's no data on EDS at all. For instance, we've got no data for EDS on surgeries at all. There's none that exists. We've got no data that exists for any kind of treatment outside of a few studies on bracing for EDS patients. So not much is out there for all kinds of treatment, let alone regenerative medicine, which is newer. So not sure I can help you there, but certainly I can just tell you my clinical experience there. Thank you, Megan. And I'm personally skipping over Sian because we're just kind of going nowhere with all of that. So thank you for reaching out. Okay, guys, so I'm coming to the end of questions here. If there's any other questions, please jump those in and I will try to get those answered. Jody, I cannot turn left or right very well. Does this happen with CCI and I think maybe AAI? Yeah, Jody. So yes, what happens generally with CCI patients, for most of them, is that the instability leads to spasm, and that spasm is what causes a lack of rotation. So instability leads to muscles trying to help stabilize, and they're just not built to do that. So they are basically just lock everything down to try to protect the structures. And so that's really where the lack of range of motion comes from. Now, sometimes in EDS patients, we can see the opposite. They are hypermobile and they don't tend to get as much spasm. Their whole life, they've had to deal with, their muscles have had to deal with instability. So it's a little different for some of the EDS patients, but for most CCI patients we see, instability causes spasm. Thank you, Damien. Look forward to talking to you on telehealth there. Mark, sure. Happy to do that. You know, listen, guys, I take this time out of my day. I try to do it twice a week. Sometimes I can't do it twice a week. But the goal is to try to answer your questions so that you are informed about all this stuff. And obviously, I have a firm belief that an educated patient is someone who makes much, much better decisions than someone who doesn't take the time to get educated. So I consider it sort of a personal jihad, if you will, to try to educate patients as much as I can, regardless of whether or not they go this way or that way or this way. It doesn't really make a difference as long as they're thinking through all these choices critically and they've got a reason for why they went left versus right, or they understand that going left might be a little riskier than going right, and therefore they can figure all that out and make cogent decisions. Something that's interesting, and thank you guys for all your kind words here. I'll put them on the screen here in a second. I will relay something that was super interesting to me this week. You know, I rarely get to be in a situation where I'm sitting in the room with a patient as a surgeon is talking about what it is they want to do. And this was kind of a unique situation. I had a special patient who had seen a upper cervical surgeon, and because I got called in the middle of the visit, I had on speakerphone, he had on speakerphone, and I just wanted to sort of get his take on this particular patient. But at the same time, he was trying to explain the surgery and what the risks and benefits of the surgery were. And it was pretty fascinating because, you know, listen, what we offer is far, far less invasive than surgery. And I'm hemming and hawing all the time. If you've ever done a telehealth with me, you might hear things like, I think we can help, or there's a 7 in 10 chance we can help, or the risks include A, B, and C, or, you know, we believe that your headaches are caused by this, etc. And it's important to talk like that with patients because patients need to hear the real deal rather than a sanitized version of what's being offered. And instead, what I heard, and it was fascinating for me, was very much a sanitized version of a skull-based decompression and a C1, C2 screw fixation surgery. The certainty was amazing to me, i.e. this will certainly help your problems. None of the risks were discussed. And there was no hemming or hawing about any of that information. So it was a fascinating experience for me to be a fly on the wall, so to speak, in that surgical discussion. So again, what it brings up for me as someone who does this kind of work is you want, and there are surgeons out there who will talk like I talk, but that's the kind of thing you want to hear from a surgeon. You want to hear things like, hey, I think I can help you, or there's a 7 in 10 chance that I can help you, or if we fuse your C1, C2, you're going to lose 50% of the rotation of your neck, or hey, try everything else before you try this. And there are upper cervical surgeons out there that talk like that, and I really appreciate them because that's the kind of thing you want to hear from those surgeons. So if you hear the opposite, which is what I heard, which is absolute certainty, then you want to run because there's nothing like that in medicine, and certainly not upper neck surgery. So anyway, let's keep going. Understand, I thought maybe you had statistics on your patient need. Yes, we do. So as I've talked about before, Anya, our research team is looking at the CCI data in EDS patients right now, and they're comparing EDS versus non-EDS patients. Now, they've got a lot of things on their plate. They're preparing, for example, a drug for an FDA IND. They are preparing data on 3 or 4 different research studies. They are comparing CFUFs versus CD271 flow cytometry data. So they got a lot of stuff going on. So hopefully in the next few weeks, they'll get me that comparison and I can share that with you guys here. But just realize that they're juggling lots of different projects. And this is only one of those projects that they're looking at. Thank you, Joe Henry. Thank you, Kristen. Thanks, Ravati, Jody, Peter. How does the PICL stop abnormal twisting of the C2? Yeah, let's see. I just have to find that picture for you, HRH. Let's see here. Let me find that picture for you, and then I can put it in a PowerPoint, and I can kind of show you what it is we're talking about there. I tried to explain this with my hand. It doesn't work out as well. So let's actually get some real pictures here. Okay, this is one for sure. So HRH, I'm just putting these in a PowerPoint so I can go ahead and illustrate them for you. And hopefully it'll make a little bit more sense than me just trying to use my hands. Okay, guys, so let's put these up. I got to remember to share my screen, which I'll do here. And then we'll go to this one. Okay, so this is an actual cervical MRI from someone's neck. And as you can see, once you blow it up this big, it's not all that clear. That's one of the downsides of even 3 Tesla MRIs. But we have here C0, which is the skull base. This is C1, and this is C2. Now, it's interesting. This particular C1, C2 joint has what's called an effusion, meaning it's got all this white stuff in it, which is basically swelling. Effusion is a medical term that means swelling. And then because it's got that, however, it highlights these joint surfaces. So this joint surface is concave at C2, and this joint surface is concave at C1. So we call that a biconcave joint. And I don't think there's another example of any joint in your body that's biconcave. But you know where biconcave joints are found in nature, and that is owls. If you've ever noticed that owls can rotate their head 360 or 270 or whatever it is, but a lot, they've got biconcave joints. So biconcave joint is one that allows for rotation. And it allows one part to glide in rotation on the other part. Now, there are ligaments that help to stabilize all of this. So that would be things like alar ligament, transverse ligament, accessory ligament, etc. So all of those things help to stabilize this C1, C2. And just to draw that here, that's C1, that's C2. And again, the problem, however, with a biconcave joint, or what's called convex-convex, is that it's inherently unstable. So whereas a convex-concave joint, something like a hip, for example, so this could be the femur, this is the acetabulum. This thing, if you take away the ligaments and the muscles, is fairly stable because one part fits into the other. But for a biconcave joint, it's the opposite. It's inherently unstable. So if you loosen the ligaments and the muscles that control this as it moves, and you're not keeping one perfectly on top of the other and perfectly centered, it has a tendency for one bone, in this case C1, to go one direction, and the other bone, C2, to go the other direction. And that just causes a twist. And we see that twist on MRIs all the time. In fact, it's rarely read out by reading radiologists, but we see it happen all the time. So C1, C2, just to summarize, is a biconcave joint. Hence, it's inherently unstable. So if the ligaments that directly control it, which include lots of different ligaments, but the main ones being alar accessory, and to a lesser extent, the ligaments out here, get loose, then it's going to rotate. One side's going to fall forward or backwards of the other. So that's how that works. Okay. Yeah, so I would agree, Ravati. Listen, I think we have all been in sales pitches, right? I'll never forget when I was This is when I was a young doctor, just got married. Maybe we just had small kids. They were 1 or 2 years old. We went down to Disney World and we got roped into this condo timeshare thing in exchange for free tickets. And, you know, it wasn't doing so well financially. So I was like, hey, free tickets, that's great. These tickets are expensive. We'll go spend an hour and listen to what they have to say. And that's a great example of a sanitized sales pitch, right? A sanitized sales pitch is there's all upside, there's no downside. And obviously it's not real. And medicine is the same thing, right? If you ever hear a sanitized sales pitch in medicine, you want to be very, very cautious because there's no such thing as a medical procedure that doesn't have risk. There's no such thing as a medical procedure that's 100% effective. So you want to make sure that you hear the opposite of a sanitized pitch. You want your doctor to tell you all the potential upsides and all the potential downsides, or at least answer lots and lots of questions about all the bad things that can happen, because that's how real medicine works. Anything else is the timeshare sales pitch. Anya, thank you. Can I ask if any EDS patients were able to get their instability significantly better long term? So for several years, they've been doing good. I know several people have had relief temporarily, but haven't been anyone that would have long-term relief. I don't just mean C0 through C2 instability, but lower spine and joints. Oh, sure, Anya, talk to my niece. She's a great example. My niece, and I'm sure she'd be happy for me to tell you this, she was a basket case. Quite literally, meaning that she was at that point, she was a grad student at Cambridge in the chemistry department, and she was almost at that point of having to leave school because she was getting so disabled. And, you know, what we did, and this is what I've done with countless other EDS patients through the years, is we started tightening down lots of different spots that were lax. And we focused the bone marrow concentrate on the areas that were very lax. And then we got into a rotation maybe twice a year for a couple of years where she would come out for spot treatments. And eventually she was able to get strong enough where I haven't treated her maybe in 2 years, something like that. I mean, we started this 10 years ago. So she's a great example of that. Now, it took more than one treatment. We had to treat some spots more than others, some spots 2 or 3 times. But eventually she got to a level of stability where now she's pregnant. Now, that's crazy. She's married and pregnant because when we started and she was a grad student at Cambridge, that wasn't even on the table. It was on the table as to whether or not she was even going to continue in grad school. So she's now pregnant, married, and and actually is starting her own company, taking all the intellectual property she developed and moving that forward. So she's a great example long-term of what's possible with that approach. Okay, guys, any other questions that you have? Happy to answer. We're knocking on the door of 2 o'clock my time. So, but if you've got any questions, this would be a good time to ask them. Here we are. Ben, how often do people improve after the second PICL? Ben, if you could put a little bit more information with that, that would be helpful because a lot of things come up for me when I read that, meaning are you talking about people who didn't respond to the first or people who did respond to the first? So I'll try to answer it as broadly as I can. For people who did respond to the first, it would be highly likely that they would get additional response to the second. For people who didn't respond to the first at all, we're still trying to figure that one out. And what we're using now as a tiebreaker, and I just did this week, is we had a patient who we treated. He reported some improvement, but not enough for me. So we ended up doing a repeat DMX. He had a dramatic improvement, probably by 50% in his C1, C2 overhang. In fact, I did that twice this week. They both improved. So for both of them, we decided to move on with procedure number 2. Mark, with my ongoing situation with the sacrum stuck in nutation, what would be the most effective orthobiologic solution for me to use to regain stability. I'm 50 years old, stem cells, PRP or PLM with dextrose. Mark, here's what I tell patients when it comes to SI joint instability, comparing those. A good baseline would be, it's generally harder to treat, not harder, but it takes more treatments to treat women with SI joint instability than men. So for instance, if we used prolotherapy, just regular old prolotherapy, it would take 6 to 8 treatments on average to treat the average woman with moderate SI joint instability. If we then switch that to PRP, you would half that. So PRP would generally be then 3 to 4 treatments to treat the average woman with SI joint instability. And then if we went to bone marrow, you would have that. So about 1 to 2 treatments with bone marrow, depending on the person. So that's generally how that works. And you can see there the differences between just using traditional prolotherapy, which is going to be closer to that PL with dextrose, versus PRP versus bone marrow. Now, for a lot of men who have SI joint instability, men tend to respond even more quickly. So there's not the huge difference there between those technologies. So PL dextrose for a lot of men will work just fine. And also for a lot of women with more mild to moderate instability. But for the big instabilities, you're really either talking platelet-based treatments or go into bone marrow. Anya, thank you. That's amazing. You mentioned that your niece didn't respond to PRP. Was it possible to predict? No, I mean, she has a rare collagen 10 disorder. And like I said, being a grad student at Cambridge, she had access to stuff through the NHS that most people don't, meaning that it's not common in the UK NHS to have the government pay for a full genome sequencing, but her professors had the right connections through the NHS, so that they got her fully sequenced. So she knows exactly what's going on, but it's a rare mutation, not a common one for EDS. So that was just trial and error, meaning that we started with just some routine dextrose prolotherapy. Then we tried PRP in some certain spots. We quickly noticed that the prolo spots were working better than the PRP spots. Then we upgraded her to bone marrow in a couple spots that worked better than either one. And so that's how we figured it out for her, looking at her response. But there's not enough research to really predict that, and certainly not in her rare collagen 10 disorder. I can tell you, though, that for most EDS patients I treat, they tend to respond to all 3, albeit slower than someone who has totally normal ligaments. So, but she, again, just has a super duper rare, specific single gene mutation that impacts collagen 10. Mark, how many treatments, we're still talking about the SI joint instability, I believe, for PLM with dextrose would likely take. For men, usually 2 to 3 is more than enough with PLM dextrose to get them stable. But again, treating all those different spots that we had talked about. Levon, how much of a play would you say biological age, state of constitution play in the amount of PICLs that you would need to achieve a good result? I think what you mean is overall health and age. Now, a lot depends on when the injury occurred. So let me give you an example. Let's say we've got someone who's not real healthy, whose neck was injured 30 years ago, and they've had a slow downhill slide with the last 10 years being miserable, and they're now in their 60s. I'm not going to have as much hope for that patient as I would for someone who is the same age, but was a firefighter, and they were in a situation where the roof collapsed and hit their head and damaged a ligament. And they're still in relatively overall good health, but they haven't been doing much for the last year because of what's going on with this very specific injury. So those are 2 ends of a spectrum for me there. So I hope that helps answer that question. Okay, guys, so I think I'll start wrapping things up here. We were talking about sleep apnea and the neck. The neck can definitely be involved in sleep apnea. The research tends to support that. You can see based on the illustrations that it all makes good sense. And if you have a lot of snoring and your partner is telling you got a lot of snoring, or friends are saying, hey, I can't sleep in the same or 2 rooms away from you because you snore like a freight train, then that's something you may want to get investigated so that you can see if you have a significant amount of low oxygen when you sleep, because that can affect things like healing. It can affect, obviously, your heart, your brain, all that good stuff. So take that seriously. Obviously, sometimes it's as simple as treating the neck. Other times it may require other types of interventions from a sleep specialist. Anya, thank you very much. Would you say that because EDS patients respond to treatment slower, stem cells likely work better than Prolo or PRP? That's been my experience, yes. It just makes things go much more quickly. And again, if we're treating the whole body, like the approach with my niece, we would spot treat certain areas that were particularly bad with bone marrow, but we'd do the rest with Prolo. Because that's a more efficient way to do it. Obviously, it required fewer bone marrow treatments. And Prolo in general was an off-the-shelf thing I could do versus having to do a bone marrow aspirate. Ben, hypothetically speaking, if my DMX doesn't show overhang improvement after the first PICL, what kinds of treatment could I pursue with the clinic? We usually do posterior with anterior, so it's certainly possible that we would look at injecting other things that haven't yet been injected. So for example, many times in the first treatment, we only go below the atlas, getting the accessory lower alar. So it might mean more aggressive treatment above the atlas after the first PICL, those sorts of things. Jody, not sure if my comment showed. Yeah, sometimes, Jody, they don't come through in order, so I apologize. I've not had trauma. Don't think I've had EDS scored 0 out of 10 on Beighton scale. Could PRP still help? Sure, Jody. We just need to know how if you're talking about CCI here, and I think you are, then we would just need to know how you got CCI so it all makes sense. Obviously, we need to get to a diagnosis of CCI as well. But yes, obviously, if you don't have EDS, that generally means a quicker recovery in my experience. Mark, how does stem cell treatment in the Kane facility work? I know it takes time to culture the cells. Does the patient typically wait locally? The stem cells are cultured. Do they travel there? Have the stem cell draw travel back? Yeah, Mark, there's 2 ways to do that. One way would be that you go ahead and travel down there for a single trip. And in a single trip treatment, what's happening is that you're going in and getting an eval that first day, and then the cells are taken that first day. The patient spends about 10 days down there while we culture the cells. We use about half the cells for the treatment. We freeze half back, and that's generally how that works. It's also possible to do a 2-trip where you either go back 10 days later or the cells are frozen when they're done growing, and then the person comes back on another cycle a couple months later whenever it's convenient. So either one can be done down there. Okay, guys, I'm gonna say have a great weekend. Thanks so much for all the fantastic questions. Again, my belief, fervent belief, and it's almost a religious belief on my part, I hate to use terms like that, that educated patients make really great decisions, and they tend to get better quicker than patients who don't educate themselves, and they tend not to get themselves backed into corners like uneducated patients frequently do. So my goal with this show is to educate you and to take time out of my day, and it's not easy to do because I got a lot of balls in the air usually, to make sure that you can make great decisions about your own healthcare. Whether you do A or B is not so important. To me, it's whether or not you know why you're doing A over B, and you've looked at all the risks and benefits, and you understand what's going on at a high level. So thank you all so much. If there's any questions I didn't get to, then hopefully Carol will pull those to the next show. I will be here on Monday doing this again. And so I look forward to seeing you all on Monday, and have a fantastic weekend out there. Thank you.